we are looking for a certain expression of a protein called as PDL1 on the top of the cancer cells.
Okay.
The higher the expression of the PDL1, the better the chance that the immunotherapy would work.
Welcome to the Longevity Decoded podcast, a thought-provoking journey into science and medicine with discussions on how to optimize your health by learning the cutting-edge tools to apply in your daily life, preventing illness and maximizing your health span. I'm your host, Dr. Guerrero.
Let's get to what people want to know. What's a tumor? People hear about the tumor. And what's cancer? Is there a difference? And some people want to just know what's cancer.
The origination of it comes from the crab, basically how we say is that it's trying to create a hole and trying to dig into it deeper into in the soil.
Okay.
It's the same thing with the tumor too. It's a normal body cell which has created some form of immortality here. It is supposed to have a limited period of time, but it keeps on proliferating. It's growing exponentially, and it is trying to create immortality here. So
is it a clone? The cells are copy-paste?
It's a clone. It's basically one particular kind of cells trying to multiplicate in high numbers, and there is the process of where there is a cell death is being arrested there. So and that is because of many things that probably we'll be discussing about what is creating these things is multifactorial things.
Yeah.
It has also been said that they found evidence of cancer way back in the Egyptian mummies too. So this is a disease that has been from the nth of time. It's not something new. It's just that as humans are living longer, and then now we're seeing more and more cancer in the community out here.
Oh, okay.
Yeah.
And in terms of, like you're alluding, in terms of the etiologies, how much of it is genetic, environment? Do we know the proportions of that, or what else?
So the genetic component, what we call is when we talk about the genetic component, we're talking about mutations happening inside the cancer cell. There's something called germline mutation, and there's something called a somatic mutation.
Okay.
Germline mutations are something that happen through birth, means you've acquired it through your parents.
Okay.
So this gene is in with you since you're born.
Okay.
When does the gene get expressed and when it starts to show up as cancer is the unknown. So it's the genotype and it's the phenotype, the word we call as phenotype. Phenotype is the expression of the gene.
Okay.
And that can happen through the course of life.
Okay.
A somatic mutation is a mutation that happens due to external factors, environmental factors, viruses,
like
chemicals, diet,
Okay.
Our lifestyle, stress. There's many things contributing to it. So as you said, in terms of percentages, 15% of the cancers are really genetically, means that's hereditary.
Okay.
85% of the cancers are environmental, viruses,
Okay.
chemicals, and things.
So definitely our interaction with the environment, lifestyle. Are you sleeping well? Are you eating well? All those are very important because it takes 85%.
Very important. Very important.
Oh, okay.
I think the great majority of the cancers are there. So the genetic component is something that we can predict
Gotcha.
by doing tests. But the environmental ones, really, we do not know how they're going to
And it's a big chunk, 85%.
It's a big chunk.
Okay. And the main killers, at least in the United States that I know, is lung cancer, number one, then colon cancer, and then breast cancer for females, and prostate cancer.
These are the big four.
Yes.
These are the big four.
And in terms of the lung cancer, what are I know it's complex. Is it non-small cell lung cancer versus small cell lung cancer, limited stage, extended stage, stage 4 for the non-small? What are the basic treatments, when people get a diagnosis of cancer, what are the things they have to know about? Like, for example, there's a surgery, what options are there for that?
So before we dive into that,
sure.
Jorge, a little bit, because lung cancer, I know that there are only few cancers that right now have screening tools.
Okay.
We'll talk a little bit about screening. Mammograms. it's very important about doing mammograms after the age of 40.
Okay.
There are certain conditions where if there is a significant family history or there's been prior exposure to some radiation and things like that,
Okay.
then the mammograms should be started at a earlier age.
Okay.
But for the general population, women at the age of 40 should start doing mammograms annually.
Okay.
So that's one for mammograms. Then you have colonoscopies.
Mm-hmm.
So colonoscopy, age 45 is the recommendation for the general
So it went
population.
down. It used to be 50.
It used to be 50. Right now, the recommendation is 45. We're seeing a lot of colon cancer very early. Not everything is genetic. It's also the environmental factors contributing to it. It's our dietary patterns and things like that,
Okay.
which have led to an increased incidence of colon cancer in the younger adults. So 45 is the recommendation. Unless there's some significant family history, there's some
Okay.
genetic component to it, we start off early.
Okay.
In women, again, we have our pap smears, which are saving lives in terms of cervical cancer.
Okay.
That's the screening for cervical cancer. For men, prostate cancer, there has been some discrepancy in how we go with the screening of prostate cancer, digital rectal examinations, and PSAs.
Okay.
PSAs have been questioned by the U.S. Preventive Task Force.
Right.
But in my practice and in the community, I highly recommend it's a blood test.
It's simple.
It is simple blood test. You are routinely doing your blood work. Please get a PSA done.
Okay.
I know it's a false positive, but
Right.
you'll be.
But you can trend
You
it.
could trend it down.
Yeah.
You could get the urology experience and things like that. Now in lung cancer,
Mhm.
we do have early lung cancer screening.
Yeah.
So the lung cancer guidelines are that if you are a smoker for more than 15 years
Okay.
and you are above the age of 53, you should be getting a low dose CT scan on an annual basis.
Oh, okay.
And this-
Non-contrast, high resolution. Right over.
and
Okay.
it's a low contrast CT scan.
Just a simple CT.
Yeah, the
Okay.
randomized trials showed that it was much superior than a regular chest X-ray, and it was shown to saving lives.
Okay.
So
Definitely.
I would definitely want your audience to ask
Yeah.
for a CT scan by their primary care physicians. If
It's
they-
lower radiation.
Low radiation.
Yeah.
Low radiation. So definitely it is.
So it's 15 pack here.
15.
Okay.
15
so
and
that's
age
basically
53.
so people know it's like you smoke a pack a day for 15 years, or you smoke 2 packs a day for 7.5 years.
Yes.
Basically.
Yes. And you should be around the age of 53 is what they took the guidelines as. So
Oh, okay.
So if you're above 50, I would say, and then 15 pack years of smoking,
Yeah.
please get a low dose CT scan.
And usually they're scanning yearly until age 80 roughly, and then,
Around
then you
age
can
80.
stop.
Then you could stop.
You have to be like without smoking for 15 years,
Yes.
roughly.
Yes.
Oh, okay, so there's an option for early detection for lung cancer,
For lung
and it
cancer.
could be cured if you catch a small.
That's the big
stage
thing.
1.
That's the big thing. So that's the big thing about lung cancer. If we are able to catch it early, it is curative.
Oh yeah,
It is curative.
that's awesome because that's the number one killer, and you could actually cure it. And most people think you cannot cure cancer, but that's an example where you can completely resect it and be cured.
You could change the course of somebody's disease here. You
Oh,
definitely
okay.
could change it. So that's important. Unfortunately, not everybody is being diagnosed at an early stage.
Yeah.
Now we are seeing cancers being diagnosed in stage 3, stage 4. Some are still being able to go for surgery depending on where the cancer has spread to, which kind of lymph node involvement is there. Is the surgeon being able to take the whole cancer out? In certain stage 3s, we are doing chemoradiation, and
Okay.
then we are also using the role of immunotherapy. Hopefully, we'll
Okay,
be talking
yes.
more about immunotherapy
Yeah.
as also a treatment modality in stage 3 cancers.
Oh, okay, so you can do this like that's the neoadjuvant chemo radiation that before you get surgery, or is what?
So that's a small subset
Okay.
where you do the neoadjuvant, where you means neoadjuvant typically means that we are doing some form of treatment to downsize the tumor and
Downstage it.
downstage it
Okay.
and amicable for surgery by the by the surgeon.
Oh, okay.
And also stating that by doing some treatment ahead of time before surgery, we probably may be also addressing some minute cancer cells if they are already metastasized outside, not visible on scans.
Okay.
We may be addressing those cells too by giving chemotherapy ahead of time. So that's a small subset yet. It's not yet panned out in a big way.
Okay.
This typically is happening only in big tertiary centers, not commonly seen in our community settings.
Okay. I want to ask you about specifically the breast cancer because this part's a bit confusing to a lot of people. The mammogram is key, you said age 40. How about this other modalities, an MRI or ultrasound? How to combine those things or what to do with that?
So, when you're doing a screening test, you're basically employing a technique that is going to be helping a large population. It has to be cost effective.
Okay.
It has to be cost effective. So, a mammogram with an ultrasound, we are able to detect a large majority of cases here.
Okay.
So, almost 80 to 85% of cancers are picked up by a mammogram and an ultrasound. But there may be about 10 to 15% of patients who may have dense breasts or the lesions may be very small,
Okay.
where there is a higher clinical suspicion for us. In those patients, we are asking them to do MRIs, which are more sensitive in catching things.
Oh,
So
okay.
it's the discretion of the physician, depending on a case-to-case basis, because MRI is more tedious, it's more expensive, it's time-consuming. We would like to use the MRI more on very appropriate patients who really need it.
Oh, okay. So it'd be like a hyperdense breast tissue that you
Yes.
cannot really see it with a mammogram or ultrasound.
Yes, some dense breast tissue
Okay.
can really obscure lesions. So we definitely need
Like MRI.
MRI on that. Yeah.
And for the colon, there's something else, a Cologuard test.
Yes.
Is that replacing a colonoscopy or not really because you're not
I
looking
mean,
at
it
polyps with that?
is an alternative.
Okay.
It is still has some false positives. Basically, you do not have cancer, but the test is telling you that you may have cancer.
Oh, okay. So the Cologuard is looking for traces of DNA
Yes.
from the tumor,
Yes.
and it could falsely interpret it like there is.
Yes. So there is the stool test is basically the shedding of the DNA
Okay.
in the stool. This could pick up early polyps because a polyp could convert into cancer eventually.
Right.
So that DNA being shed may be giving us an indication that this is cancer.
Okay.
I mean, it is an alternative, but I still urge that if you are in good health and if
Right.
if there is no contraindication to
Right.
undergoing anesthesia and doing a colonoscopy,
Yeah.
I would prefer patients looking for colonoscopy.
Yeah, because actually most of the tumors they start like a polyp, so you would see that physically with a colonoscope, and you could resect that.
Yes.
And if you do the Cologuard, like you're saying, it might come back negative. It just didn't detect enough DNA.
Yes.
And then you tell them, oh, you're good, and they're not good.
Yeah. I mean, the question of falsely saying it's negative means that is not an issue here. More
Oh, okay.
with Cologuard, it's more about the falsely being saying as positive.
Oh.
But I would not still recommend it as a complete alternative to colonoscopy. Because colonoscopy, we are also addressing the prime issue there. The issue of if there is a polyp, which takes about 3 to 5 years to convert to cancer, can be removed.
Oh.
So we are also doing, it's a diagnostic thing. We are
Yeah.
able to diagnose it. And also we are doing a therapeutic intervention. We are also doing an intervention to take away the source, which can convert to cancer.
Oh, okay. That so you can actually intervene on it.
Intervene on it.
Okay, perfect. And then going back to the lung cancer, in terms of the treatments, the options, including everything, immunotherapy and those things. You have chemotherapy, radiation, surgery, and then we have something immunotherapy. What's immunotherapy? It's for people to understand.
So lung cancer has changed significantly in the last 5 years, 10 years. I mean, no two lung cancers are the same. Now, if you go to stage 4 lung cancers, we need more information on the lung cancer. First is the histology. Histology is the tissue. What kind of cancer is it? As you were getting to saying what is small cell and what is non-small cell.
Yeah.
So it's the kind of tissue that is basically driving the cancer there.
Okay.
So predominantly still 85 to 90% of the cancers are non-small cell lung cancers and only 5 to 10% are small cell lung cancers. In the non-small cell lung cancer, the field of non-small cell lung cancer has grown exponentially. are looking for targets inside the cancer cells now. So there are some drivers, what we call as these are the specific mutations that are driving the progression of cancer.
Okay.
We have about 7 targets that we know right off that has treatment options in the form of a pill.
Okay.
So we have specific non-chemotherapy, non-immunotherapy pill form of treatments that have been approved in those specific cancers.
Okay.
Now, what's the percentage of that? It's still around 20 to 25% of the cancers only have it.
Okay.
And we are mostly seeing this in non-smokers.
Non-smokers, and that's not immunotherapy.
And that's not immunotherapy.
Okay.
And that's not immunotherapy. So these are targeted drugs, specific mutations called EGFR, ROS, ALK, MET, RET, NTRK, HER2/neu. So
Okay.
these are all the things that we are actually looking for in the cancer immediately when the cancer is being diagnosed.
So it's some mutation, like a receptor on the wall.
It is the gene mutations
Gene mutation.
inside the cancer cell.
Oh, okay.
These are these somatic mutations that we talked about that have happened over the course of life.
Oh, okay.
So those mutations, and we are specifically targeting those mutations to arrest the cancer cells.
Okay.
And we believe that these mutations are the driver. When we call them as a driver, they are the main reason behind the cancer cells
And why it keeps them dividing.
to divide.
So you're tackling exactly
So we're
targeted.
specifically targeting those. Still, the great majority, still 70 to 75% of the cancers are being treated with chemotherapy.
Okay.
But we are also adding immunotherapy to this thing. And what is immunotherapy? So, few years ago, probably if it came into your into your domain, there was something on the Time magazine that said, "The cure lies inside you."
Oh, I remember that.
Yeah, the cure lies inside you was basically it's your immune system. Your own immune system has the ability to identify cancer. I mean, as we're going by our lives, there is always some form of cancer cells that are developing inside us.
So that's why, for example, somebody is very stressed out, not sleeping, not eating well, the immune system goes down, and that could lead to a cancer flourishing.
So there are all these theories that
Right,
we still are not sure,
Okay,
and
okay.
everybody is different here. So the general idea is that the body, as it goes through so much of stress or environmental exposures, chemicals and things like that, there is a cancer cell that is being created.
Okay.
But your body's immune system, specifically the T cells, when you
B cells and
B cells and T cells, the T cells are the ones that are really identifying these cancer cells,
Okay.
and they are eliminating them. Now the theory is that people who develop cancer, they are basically developing some form of a resistance that the immune cell is unable to recognize them as cancer cell. The way I explain my patients is that I bring them to this Harry Potter kind of thing, where
Okay.
you wear an invisible cloak,
Yeah.
and people are invisible because of the cloak.
Yeah.
So it's like the cancer cell has created an invisible cloak on itself.
Mm,
So these immunotherapies, what we are doing is we are unmasking the cloak.
okay.
We are trying to take the cloak away. We are telling the immune cell, hey, that's cancer. Now go kill it.
Okay.
So it's a form of teaching the immune system where to identify cancer.
Okay.
I mean, we have had some success on it. It's not like a slam dunk,
Mm-hmm.
but this is a beginning.
Does it happen, like, for example, somebody has an EGFR and you have a medication that can target that, the cancer regresses or shrinks quite a bit, and then after a year, 2, 3 years, can they have a second mutation, like ALK mutates, and then they need to be rebiopsied and see if they can find a second mutation and tackle it? Have you had patients that
That is in extreme situations,
It's extreme?
because
Okay.
because an EGFR is still a driver mutation. When I mean a driver, means it's the main cause of the cancer.
Okay.
They are internal mutations that are happening inside the EGFR.
Oh.
Like
Okay.
T790M mutation is a specific mutation that is developing over the course of time.
Okay.
These mutations are developing as the cancer continues to be there in the body.
Okay.
So now we are trying to identify specific drugs to tackle those kinds of mutations.
Oh, so
We
we
have
don't have
drugs.
those yet.
We have drugs for
There is.
T790 mutation. We
T790, okay.
already have we have drugs for it. And there are a lot more drugs which are being in the development, understanding that as the disease progresses, we are going to identify what those mutations may happen, and we address at that time.
Oh, okay. During my time at Moffitt Cancer Center, I was doing a lot of biopsies of the lungs of tumors, and I saw a lot of patients talking about that they received their CAR T therapy. Is that an immune related with T? Is that T cell?
So yeah, so CAR T cells is basically another form of immunotherapy.
Okay.
It has not yet panned out in the solid tumors. It is being investigated heavily. It's a lot of clinical trials are going on.
Okay.
But right now, the FDA approved indications for CAR T cells are in lymphomas,
Okay.
in some form of leukemias, and in myelomas.
Okay.
So these are the three fields. It's mostly in the liquid tumors that we have had success with CAR T cells. What does CAR T means? It's basically you're going to take your blood, you're going to take your T cells out.
Okay.
We're going to attach a certain antigen on the top of the T cell,
Okay.
and we reintroduce it back to you, which can specifically go and attack the cancer cells.
Oh, so they
So
will
we're
guide them.
creating a environment outside the body,
Mhm.
teaching we are basically priming the T cell with a certain antigen. Means it's basically it knows where to go and attack the
Sort of like
cells.
a GPS, go there,
GPS and go and yeah.
and that's been effective.
It's been very effective in lymphomas. Basically, we are basically patients who have failed for frontline chemotherapies in diffuse large B cell lymphomas. This has led to curative options here.
Now, how about like treating lung cancer just straight with immunotherapy or an EGFR blocker and no chemo radiation? Is that a scenario that you can have something like that, or you have to give them chemo if their stage is high?
So there are some patients who
Okay.
do not need chemotherapy. There
Okay.
are some patients who do not need chemotherapy. We are looking for a certain expression of a protein called as PDL1 on the top of the cancer cells.
Okay.
The higher the expression of the PDL1, the better the chance that the immunotherapy would work.
Okay. That'll be
So
something like Keytruda that
yes, the
tackles?
Keytruda
Oh, okay.
is the one. We have Keytruda, we have Optivo, we have
Okay.
Tecentriq, we have Durvalumab,
Those are
Infancy.
PDL1 inhibitors?
They're all PDL1 inhibitors.
Okay.
Some are PDL1 and some are PD1. There's a little difference to
Difference, but
both,
it's
but the
similar concept.
similar concept is similar. The higher the expression of the PDL1, that's 50% or more, or if you're going into the 90% and your disease volume is very minimal, then only using immunotherapy is an option. The only immunotherapies that I would use in my patients is that when the cancer volume is large, means if I expect that the cancer would not kill my patients within the 9 to 12 week period, because these immunotherapies take a while to act.
Oh, okay.
They are not a direct way of killing cancer. There's an indirect way of killing cancer. We need time on it.
Okay.
And if I see that, if it is within 9 or 12 weeks, if the patient may not make it, I would use chemotherapy on them.
That makes sense.
So
But
I need
for
an
some
active.
people, some people are hesitant in terms of the chemotherapy. It's pretty strong medicine.
Yes.
And some people wonder, can I just do the immunotherapy? So there's some scenarios.
There are some scenarios. I mean, it's all about when did we catch the cancer. If it came early, if it was only a little bit of pleural effusion, the disease volume is low, and the PDL1 expression is high, yeah, immunotherapy.
Okay.
But then you have large volume disease. You see patients in the hospital. You're
Right.
trying to do thoracentesis.
Right.
You're trying to see tumors compressing into the airway, and you're
Yeah.
having difficulty. We need to act with chemotherapy on those patients. Did we catch the cancer? If it came early, if it was only a little bit of pleural effusion, the disease volume is low, and the PDL1 expression is high, yeah, immunotherapy.
Okay.
But then you have large volume disease. You see patients in the hospital. You're
Right.
trying to do thoracentesis.
Right.
You're trying to see tumors compressing into the airway, and you're
Yeah.
having difficulty. We need to act with chemotherapy on those patients.
Okay.
That would give us the faster response.
Okay. Some people are worried about radiation and the side effects of that. Is there more focal radiation you can get, like a cyber knife? Is there something else that could be like, for example, like a lung tumor? Instead of radiating the whole field, is there new technology that can just do a more straight, like a positron or something, straight beam,
So
or in other parts of the body?
So in the field of radiation, though I'm not a radiation oncologist,
Right.
the field of radiation has a role in early stage lung cancers.
Okay.
If we see a very early stage one cancer, but unfortunately, if they have very poor lung functions or they're not able to go for surgery for reasons related to heart related issues and things like that, where the anesthetist would not clear them,
Mm-hmm.
or if they have bad emphysema and the lung capacity is not adequate, then there is a role for this very specific radiation, what we call as stereotactic radiation, or
Okay.
it's only a 2 or 3 day treatment where you go and you're burning the area around the area where the cancer is.
Very focal.
Very focal,
So
very
side
focal,
effects are minimal.
very minimal. The equipment that we have right now, there's newer, there are these new linear accelerators, true beams, all these new
Yeah.
machines that are available
Yeah.
are trying to minimize the side effects, the
Mm-hmm.
the collateral damage, what we would call.
Yeah.
We're trying to minimize it, but still there are still side effects to it.
Of course.
And there are these newer machines that have come up, but the cost is really high. We've got these new machines called proton therapies.
Okay.
The problem with proton is that they have not really shown to be better than the
The stereotactic regular one.
the regular ones that
Yeah.
we're using. But the only thing that has been definitely proven is that the side effect profile is much less when we use proton therapy. But to have a proton machine is close to $150 million.
Oh wow.
Yes,
That's-
whereas the other ones would be probably around $2 to $3 million.
So it's a gigantic
So it's a
difference.
huge, gigantic cost involved in it, and not everybody is able to afford it. It's only the
Right.
big hospitals are having it. And will it really help a large population? That's the unknown.
Oh, okay. That
That's
makes
the
sense. Definitely, these machines have improved. When I was doing fellowship at Georgetown, they would ask me to go with a bronchoscope and typically use electromagnetic navigation and travel to the tumor to put these little gold markers. They're called fiducial
Fiducials.
markers. And they usually wanted 3 so that the cyberknife radiation, stereotactic radiation cyberknife, will be able to target the gold markers and be more accurate. But then when I was at Harvard, I said, okay, do you want me to put we had a case. Do you want me to put some fiducial markers so you can do the stereotactic radiation? And they were like, we don't need that. I'm like, what? No, we can use the linear.
Linear accelerated.
So they're not needing the fiducial. Things are evolving and they're improving quite a bit.
Definitely.
Yeah, I wanted to ask you about this, that people might hear about this liquid biopsy. They take blood and what's that?
So liquid biopsy is basically right now, as we talked about in our lung cancer, we're looking for those specific mutations, and traditionally what we have done is that we were trying to get those mutations based on the tumor specimen that was available.
Mm-hmm.
So technology evolved, stating that when these tumors shed DNA into the blood, we're going to capture the DNA and see if we can find these mutations, and we have been able to find it.
Okay.
And also, we now do we definitely test the tissue, and we also do the blood, because we think that there is something called as tumor heterogeneity. Heterogeneity means differences in the tumor itself. At one place, you could see some mutations; at other place,
Oh.
you may not be able to. So to be very sure that we're not missing some treatments, we are definitely checking the liquid or the blood also,
Okay.
to make sure that we're not missing any targets that are available for treatment.
That's interesting.
Yes.
I forgot to ask you about something about the BRCA genes for breast. Who should get tested for the BRCA, and when would you say you need a prophylactic bilateral mastectomy?
Okay, so that's again, it shifts our thing into the germline, which means
Okay.
that's something that you are born with.
Okay.
So BRCA genes are the genes that you are basically checking on patients who you suspect that there is a family history of cancer.
Okay.
The guidelines are that you should have at least 3 family members with either breast, ovarian, pancreatic, prostate cancers, and at least one of them should have been under the age of 50. So these mutations, they contribute to cancer at a very early age. So these are the patients that we are suspecting, and we are doing the genetic testing. The Ashkenazi Jewish population, there is a very high incidence of BRCA mutation in
Oh, is that
there.
right? Yeah.
So just being an Ashkenazi Jew, you qualify for doing the testing.
So you could be a 23-year-old girl and check it out.
You could check it out. And
Okay.
now that these tests are so easily available, the cost is very minimal. It's direct to consumer. Like you may have seen, most of your viewers might be
Yeah.
doing 23andMe.
Yeah.
They could do now the germline testing. It's available. It's at, the out of pocket is $200.
Oh, wow.
I did it for myself, man.
It's really good.
I had to do it because I just wanted to know if there is anything that
Yeah.
is there. We could intervene.
Right.
The idea is that there are guidelines to tell us when do we start screening, what to do about it. And right now we have a panel of 84 genes that we check for. It's not only the BRCA that we know about. Now there are about 84 genes that are available for us to tell us what is your risk of cancers.
And where can people get that test?
They can easily get it available at the primary care. They can
Okay.
get referred to an oncologist. Every oncologist's office has the ability to perform this test. It's a
Okay.
simple blood draw. It takes about 10 to 12 days to get your results. It's available online. You have genetic counselors who are going to go through each and everything in the event of something being positive. What has to be done in the event of a positive gene.
Okay.
You're given specific instructions on
With your results.
with
You
the
get the results and it has
with
the...
results, with the guidelines, everything very clearly formatted for the patients to do over the course of life.
Okay, but can somebody just go online without a doctor and try to find the test and buy it?
You probably would need, as of right now, I think you still have to use a physician
Okay.
to do it. I think the question is also the interpretation of the
I think that's
results.
the main thing.
The main thing is interpretation.
Yeah.
What to expect out of it, because there are some genes which may be of no significance and it may confuse patients.
Yeah. Just mental stress for nothing.
So you better off talking to your primary care.
And they just ask, I want the 84 genetic test, or what, how do you call
So
it?
as I said, if you that also varies again. If
Okay.
somebody already is known to have a BRCA gene in their family, then we would specifically ask for BRCA. If somebody
Okay.
has something called as a Lynch syndrome in the family,
Yeah.
we would specifically ask for Lynch. If there is something called as ATM mutations and things like that. But if it is unknown, then we would do a whole panel.
So it's just say, I want the whole panel
we would do
for the
whole
genetic
panel.
screening for cancer and the primary
mean-
care, or they can send it to you or an
We
oncologist,
could definitely.
and they can order it.
I mean, the cost is so in the beginning it used to be very expensive. Now it's these companies are able to do it because of the technology.
Mm-hmm,
The technology has become so easily available that they give it at a cost of $200.
Oh, okay, really good.
Yeah.
We're talking the other day about fasting. A lot of the tumor cells, they're very dependent on the glucose, as I understand. So in theory, and it's maybe not all of the cancers, but in theory, tumor cells really struggle to continue to divide and grow in a very low glucose environment. Do you know anything about any trials or treatment protocols where they incorporate fasting, or have you had a patient that fasted for 30 days, 60 days, and the tumor shrank? Have you seen a role in the fasting or being on a ketogenic diet for cancer?
So there are no randomized trials
Okay.
to predict it. In theory, that definitely sounds good, but there's too much complexity inside a cancer cell, Jorge.
Okay.
I mean, there's not one particular thing that is driving the cancer there. Eating right, sleeping right, exercise, doing all of these are advocated.
Okay.
These would prevent a cancer from happening, but once the cancer has developed, I do not know if these things are really going to change it. It may be complementary to the treatments that we do,
Okay.
but I would not say that these alone would be enough to suppress your cancer.
Okay.
I do not have enough information on
Yeah,
that.
there's no randomized
No
prospective
trials to say that.
Yeah.
Yes, I mean, there may be a one-off case where things might have worked out. My common thing is that if I tell my patients that, if they give me a case and I said, okay, you take 100 of them, you take them to the Niagara Falls, let 100 of them jump, there's a possibility that one might be alive.
Right.
So you cannot go by that one person, you
Yeah.
got to go by the 99.
Okay, correct.
So
It's more like an anecdote.
anecdote. So you just cannot go by that one particular case where There probably was something about it.
Mm-hmm.
The ketogenic diet might have worked out on them, and I'm very happy for that person. But
Yeah.
I cannot advocate the same thing
Right.
for the rest of the population because there's too many things going on inside the cancer.
Oh, okay.
It's too
So,
much.
because I'm worried a little bit about that because I've heard stories of people having diagnosed cancer and they say, oh, I don't want to get that chemo. I'm going to go ketogenic for 6 months. And you hear stories, they come back and the tumor was stage 2 and they come back at a stage 4. Have you seen people trying
I have.
natural things and they come back and it's worse?
I've seen that, we hear a lot of stories, there's a mistrust. There is a mistrust. There's a lot of mistrust stating that, pharmaceutical companies are trying to prevent the cure for cancer for their
Yeah, I've seen
personal
that.
needs and
Pretty
things like
paranoid.
that.
Well,
I mean,
conspiracy.
I would, that's not.
It doesn't make any sense. I mean,
doesn't
there's some
make
corruption
sense.
in everything. There's
Everything,
corruption. There could be corruption within a pharmaceutical.
Yes.
There could be a corrupt doctor working in the pharmaceutical. But, the natural course of cancer, we know it. We know it responds to chemotherapy, responds to radiation, immunotherapy. So people should be very cautious.
Be very cautious with what kind of information. It's all about the information being given to them, how you process that information. That is extremely important. I do a lot of clinical trials, and to be honest, we do so many clinical trials, and I would say if you do 100 clinical trials, one drug gets to see the day of light.
Okay.
There's so many drugs that never see the day of light.
And that company, that pharmaceutical, wasted millions of
Millions of
dollars.
dollars,
And they took it at a
millions of
loss.
dollars.
That's it.
We've seen that. We've seen that happen.
So it's
again
not
and
like
again.
every time they come up with a drug, it's guaranteed
It's
because there's
not.
corruption.
It is not. It
You
is
see-
not.
okay.
I mean, there is more drugs that are discarded, that they are closed down during the trial, saying that the side effect profile is not favorable. We don't see a benefit, even if everything goes fine. If you say that the drug did not show any improvement in survival,
Mhm.
those drugs would never get to see the day of light.
Oh, okay. And are you currently doing any? You said you're doing some research trials. You're involved with them. I just want to
Yeah.
talk about that.
So we do clinical trials at our facility. Clinical trials are of different kinds. Everybody has to look for what trial is more appropriate for them.
Mhm.
There's something called as phase 1, phase 2, phase 3 trials. Phase 1 is basically you're being given a drug which is being looked upon as whether it's causing any side effects or not.
Okay.
That's all that is being
Side
looked
effects
at.
for the
side
one.
effects in phase 1.
Okay.
In phase 2, you're basically looking at a small population of patients, trying to see whether the tumors are responding to treatment or not.
Okay.
That's typically a phase 2. In phase 3 is basically what you're doing. You're taking a larger population of patients and then you're randomizing into two groups. You're giving one set of patients the current standard of treatment, whatever is the standard of treatment right now.
Okay.
And then the other set, you're giving the trial drug. And then you're going to compare and see, did the trial drug do better than the current regimen? And then only would the drug ever see the day of light.
So it's very strict.
So there's a process to it. So
And it's monitored by the FDA. There's some agency regulating
there are
this.
some serious regulations, and then people running clinical trials, we have to document every small side effect, every lab, everything is to be written. FDA can come uninvited. They can audit you.
To show up to your office.
This can have some serious implications on the physician if it is not done in the proper way.
Mhm.
The reputation of the physician, their licenses, everything is at stake here. So clinical trials are done at a very high standards, very high standards.
Okay.
We in our facility, we have 3 research coordinators who specifically look for it. We have our bigger partner, the US Oncology Network, who monitors it. They have their own auditing, even to make sure
Like
that
a separate from the
audit.
FDA.
Yeah, they are auditing our information, and if the FDA asks for any paperwork, we should be producing to them immediately. So the paperwork, the paper trails, everything is documented.
Okay, so people shouldn't be
I would
too afraid of.
if they have any
chemotherapy
questions, they
or-
should always come and talk to their doctor, understand what the clinical trials are, there's a lot of information out there for
Oh, okay.
so.
So these drugs are very effective, But if we look back at the last 50 years or so, how much has the mortality improved overall? Cancer is a very tough one. So we're not expecting huge numbers. So the mortality, my understanding, it hasn't been incredibly better. It has improved, but a lot of people, they get the treatment and they still die with the cancer.
Yes. I mean, I have to agree on that, Jorge. I mean,
Okay.
the thing about cancer is that, as we talked about, no two cancers are the same.
Okay.
Why are some cancers doing better than the others? There's something inside the cancer that is responding well to treatment.
Mm-hmm.
Our job as doctors right now is to identify who these patients are.
Okay.
Trying to find targets, trying to say that, hey, if you have this particular protein, you have a better chance of response.
Mm-hmm. Mm-hmm.
You are basically giving the patients more insight on that this is your percentage of your cancer going to respond.
Okay.
And that also is so important for the patient, because why to put them through all the side effects if you know
Yeah.
that this is not going to.
Okay.
So this is these are the things that are in evolution right now, and we are understanding it as every day goes by. We are able to get more and more information.
Yeah.
And we are able to present it to the patient. Patients might be dejected, but we see a good target on it, and we
Mm-hmm.
try to pursue the patient, saying that this particular target, like
Yeah.
an EGFR,
Yeah. Yeah.
you have a very good chance that this cancer is going to respond. Please
Mm-hmm.
do not give up, and we push them.
Yeah.
Though it's not curative, but you have
Right.
patients living another 4, 5, 6 years.
I think that's a big point, and I've had patients that they've said, I've been fighting cancer for 30 years. And then I was thinking, okay, they will die from the cancer, but they have received another 30 years of life and hopefully good quality of life, or they're spending time with their loved ones. So I think we should not just look at the mortality, but the health span they have,
Right.
which is increased by treatments for
I mean,
cancer.
if you go by the statistics, predominantly cancers are happening after the age of 65 to 70.
Okay.
The normal life expectancy in this country for males is 83 years, women is 85 years.
Mm-hmm.
I mean, if we are able to make cancer a chronic disease, if we find ways, like, we know
Like
that
hypertension, you're taking a pill forever.
your diabetes,
Or
you have diabetes, you have
Yeah.
hypertension, you're going to live it till you die. You're going to have hypertension all your life. If we could do that in all cancers,
Mhm.
like in some estrogen positive stage 4 breast cancers,
Okay, yeah.
these patients are living 8, 10, 12 years right now after the stage 4 diagnosis. So
Oh,
if you
wow.
are
That's a
70
lot.
and you get diagnosed with a stage 4 estrogen positive cancer, and you
Mhm.
take a pill every day, and then we get you to 83, 85 years.
That's excellent.
That's-
Amazing.
That's what we're trying to do here. We're trying to make it a chronic disease.
Okay. So
We're trying to make it a chronic disease. So that's the idea behind it. So I think the eventual goal is that we may not be able to prevent the initial event,
hmm
but if we can find ways how to prevent the spread of cancer,
Okay.
if we find more targets on how we could prevent the cancer to spread to other areas and we contain it, I think we're going to give more life to our patients.
Oh, absolutely. So it's
That
definitely
would be the ultimate goal. I mean, to breathe is to get cancer. We cannot be quarantined, and we cannot
Right.
live. So it may happen.
So in theory, we're developing cancers constantly,
Constantly.
but the T cells from the immune system are tackling it,
Tackling it.
killing them. You don't even know it happened. I might have had cancer a week ago.
Yeah.
It's gone.
Coming to the point, I mean, you may be asking that question later on, but the DNA test that we talked about,
Mhm.
the circulating DNA cells. So
Yeah.
patients always saying that, how come the blood did not pick up my cancer before? You've been doing all the blood tests and
Right.
you have never picked up cancer. We do not have the technology. We do not have the technology. In the near future, it is expected that we are doing clinical trials in our office on that too.
Okay.
We are basically trying to find if we can do a blood test and we can say that there is a possibility that you may be having this particular cancer.
hmm
Let's get you scanned. Let's get you a colonoscopy. Let's get you a mammogram. Let's do a pap smear. Let's intervene based on this blood test.
Okay.
And this may be the answer as we go forward, where we may be able to capture cancer at a very, very early stage and hopefully will relate to cure.
Okay, so that will be detecting in the blood, for example, traces of DNA again.
Yes.
That would be amazing.
That would
Because
be
the cancer could be a few cells, in theory,
a few cells.
or a tiny little tumor.
Yeah, the question lies is that, how do we, over the general population, how are we going to get that particular test?
Does
Is there
everybody
any,
gets a liquid biopsy?
yeah, is it, and then will there be a discrepancy in each and every gene there? How are we going to standardize the test? Those are the logistics that are currently being looked into. There's something called methylation techniques that they're looking into. Hopefully, this will translate into some form of approval by the FDA, where you go to your primary care, you do your regular blood test every 6 months,
Like
you
a
do your
CBC, BMP,
CBC,
and you get that liquid
your
biopsy.
thyroid test, you do your
Yeah.
lipid profile,
Yeah.
you do your liquid test also. Just see at it and say, hey, everything looks good.
Mhm.
Probably you don't need a colonoscopy this year, or you don't need a CAT scan this year. I'm just saying that,
It could be like potentially look like that.
potential. I mean, unless we run trials and we really show that.
I guess in theory they could make it that is looking for DNA, but with some specificity. Like for example, this looks like it's it could be something from the intestines or the GI tract versus a pulmonary tumor versus a brain tumor.
Yes.
And then okay, I'm gonna do, let's say, a brain tumor. I'm gonna do a brain MRI.
So probably they are looking for signatures to say that this particular signature is coming from the colon, or this is coming from the lung, and this is a tumor cell. So let's do the next test for them. Let's get the scan. Let's do the colonoscopy. Let's do the endoscopy. This might lead ways to pursue testing more sooner than to delay things. A simple blood test might give us that edge.
Okay. Now, the Kardashians have made very famous the whole body MRI. They're getting this whole body MRI. They're promoting the whole body MRI. I'm not attacking the Kardashians. I'm just saying. So there's people doing, I guess you have to have money. Like, is there any data that doing a random whole body MRI could prevent cancer?
They have the Kardashians, they have the money. So, I mean, MRI, it's not feasible as a screening. As I said, screening should be something that is cost effective, and it has to work in the general population. A whole body MRI would take you 7 to 8 hours to do a whole body.
Oh, so you're laying down for 7-8 hours.
6-7 hours of dedicated imaging that you're doing.
Mm-hmm.
It's not going to pan out in the general population. We do not have enough MRI machines to screen our general population.
Oh, okay. So I guess you have to care about everyone.
Everybody.
But somebody with a lot of money, they could do it. Maybe they find something, but they could also get like false positive. Called like they have a lipoma, which is like a fat tumor around the kidney, and it's benign. They've had it for 30 years, and they end up with a kidney resection and complications, and it was not necessary. I guess that could happen.
It could happen, yes. We do all these tests, and that we pick incidentalomas. We're picking things which we did not expect. Then we probe into it. Sometimes it may go.
There could be bleeding complications.
A lot of things. So I think we follow the guidelines of screening and then stick to that.
Oh, okay. Do you remember any case of somebody that you detected genetically ahead of time, and you were able to treat them because of the genetic result and prevent the cancer, or tackle it really well, that their lifespan increased dramatically just because of the genetic test that they brought or that you discovered?
I personally,
Because it's a lower percentage.
it's a very lower percentage,
Yeah.
But we've been able to identify after they get the diagnosis. They come to us, and then we've been able to give them guidelines on what to do next,
Okay.
how to prevent the next cancer. Because some genes, you may have a breast cancer, but at the same time you are also susceptible to have an ovarian cancer
Oh, okay.
with the gene. So we would recommend them to do
Does one of the BRCAs too?
BRCA genes, yes.
Yeah, okay.
So when you have a BRCA, you're basically telling them that you may want to even take your ovaries out, because that would put you at a risk for ovarian cancer as you go in life. There's about a 40 to 45% chance of in your
Pretty
lifetime. Very high. Yep. And breast cancers, we're basically telling if one breast is already affected, the chance of the other breast having cancer is about 80%. So you rather would want to do a mastectomy and prevent yourself from getting another cancer there.
So in those cases, you can prevent it 100%. Remove your ovaries, there's no ovarian cancer anymore.
Cancer, you're taking your chance way higher. Yes.
Okay. So in general, to summarize a little bit, definitely in order to prevent the cancer, a lot of it could be lifestyle, eating well, exercising, all those things. Decrease your stress levels will be a way to prevent all those somatic type of cancers.
Yes, we are definitely. I mean, those are the general. Yeah, eating right, good body mass index,
Okay.
cutting down on processed foods, cutting down on carbonated beverages, um, trying to have adequate sleep,
Okay.
decreasing the cortisol levels in the body.
Okay. Yeah. That's the
Putting
stress hormone,
stress
cortisol.
hormones. So
Is there
these are
any? Let me cut you. Sorry. Any supplements that they've studied? Some like randomized trials or not, but like that
supplements have
that could
really
prevent the cancer.
the only one that has really panned out is a low dose aspirin, which has
Oh, interesting.
shown a 30% reduction in colon cancer.
Really?
Yeah.
I didn't know that one.
That's the big trial that was done. A low dose aspirin, 81 milligrams of aspirin, has shown a 30% improvement. I mean, reducing chance of colon cancers.
Do they know
There
the
are
mechanism? Because I don't see it
it's something
right
about
up
the
front.
cyclooxygenase
The
thing pathway.
cyclooxygenase.
So
Okay.
there is something that is
Yeah, we
contributing
don't
to
need to
it.
get into that because it'll be confusing to people.
But that is the one thing. I'm not aware of other supplements that are really leading to lesser chance. But when we are treating our patients, I've used supplements in terms of minimizing their inflammation and things like that. There are drugs which have side effects, and we use
Okay.
supplements to minimize those side effects.
Oh, okay. So it'll be more for the side effects.
Side effects. Like an example would be anti-estrogen therapy for our breast cancer patients, where there's a lot of pain in the joints, inflammation in the joints.
Mhm.
So I advise them to take turmeric.
Oh, okay.
Turmeric has a lot of anti-inflammatory properties. So and then there's something like when you have neuropathy, when you have tingling and numbness with the chemotherapy and things like that.
Mhm.
In those situations, I've advised them to do acupunctures.
Oh, okay.
Yeah, they have shown to have benefit. Then we've used some glutamic acid, which has helped in neuropathy symptoms. So there are these non-FDA kind of
Off-label?
off-label things
Yeah.
to help with the side effect profile.
Oh, okay.
Definitely.
So it sounds like, cancer is very complex, multifactorial, and most of it is somatic from the exposure of the environment, and about 15% is genetic, which you could try to test ahead of time if you have family history or something that will trigger that. And cancer, although it's a difficult fight with the cancer, it is treatable. In some cases, if you detect it early, it could be curable.
Yes.
But we've been able to expand the lifespan of people significantly, give them some quality of life, able to spend time with family and friends, and so it's definitely worthwhile not giving up. When you get a diagnosis of cancer, they should go see an oncologist like you, do all the homework, if indicated, genetic testing, and then tackling the cancer as early as possible.
It's possible.
Correct? So
Yes.
if people want to find you, it'll be Cancer Care Centers of Brevard
Yes.
in Palm Bay. Is that right?
In Palm Bay,
Okay.
we are a group of 9 oncologists. We are 6 medical oncologists. We have 3 radiation oncologists.
Okay.
We practice in the county of Brevard. We have offices all the way from Merritt Island down to Palm Bay. We
Oh,
have
okay. So multiple
we have
offices.
multiple
Pretty big.
offices. We have multiple physicians. We have nurse practitioners, physician assistants. We have research coordinators. We are a comprehensive cancer center where we provide all the cancer services that are required. We do medical oncology, radiation oncology, imaging. We're doing genetics and research, which
Okay.
is the key component to cancer treatments.
Okay, excellent. So if the viewers want to see, if possible, want to visit you, hopefully they don't have cancer, but if they need your help to visit Dr. Pavan Kancharla, they can go to www.cancercarebrevard.com. That's your website. Again, www.cancercarebrevard.com. And the office number is 321-725-8300. Again, 321-725-8300 to see Dr. Kancharla, one of your colleagues,
Yes.
if they need any help. I think this conversation was very invigorating, very exciting. I did learn a lot, although I'm a medical doctor with 4 board certifications. I still don't know enough about cancer. It's very complex. That's why we need an oncologist. So thank you for everything. And, the audience is getting this at zero cost. They're learning from this, and they can take this information as an educational tool and take it to their doctors. And if they need any help, they get some guidance from this.
Definitely.
Yeah. Thank you for your knowledge, Pavan.
Thank you. Thank you,
Thank you for
Jorge. Thank
coming.
you for having me. Thank you.
My pleasure.
Thank you.
If you're learning and or enjoying the podcast, please subscribe to YouTube. You will support the podcast tremendously. Another way to support the podcast completely free will be to not only subscribe to YouTube, but to subscribe to the podcast on Spotify, and we're also on Apple Podcast. Also, please try to leave us a 5-star review both on Spotify and Apple Podcasts if you're enjoying and learning from this. Please subscribe to our newsletter. You can do that by going to our website, which is www.jorgeguerreromd.com, and you will be able to subscribe there, put your email, and you'll start getting a bi-weekly email where you're going to get different protocols for longevity that I have, and you're going to get the overall picture of how I view health and how to maximize longevity. So I'll encourage you to do that as well. Finally, make sure you follow us on all social media platforms. There, you're going to be on top of the latest news regarding longevity medications, longevity supplements, longevity protocols, anything new that I'm doing, everything that I found in terms of cutting edge for medicine, cancer, and general health. And you will know what are the incoming episodes for the podcast, and which guests will be coming to the podcast for you to stay on top of things. We are on virtually all social media platforms. Is the same handle or name for all of them. That will be at Jorge Guerrero MD, or JorgeGuerrero MD. So very easy to find. We're on Instagram, TikTok, and Facebook, as well as Twitter, now called X. Lastly, I want to thank you for joining this thought-provoking journey into science and medicine, where you find discussions on how to optimize your health. I provide you with the cutting-edge tools to apply to your daily life that will prevent illness and will optimize your lifespan, and more importantly, your health span. Thanks for joining. We'll see you on the next episode.